Now we invite Dr. Satish Adiga to speak on in vitro spermatogenesis opportunities and challenges. Over to Dr. Satish. Delegates can hand over the questions in a piece of paper to the chairpersons.
Very good afternoon and good morning, everyone. I'd like to thank the organizers for inviting me. And I realize that my topic is somewhat different from what has been the focus for this workshop. But I'm glad to tell about this in vitro spermatogenesis, the opportunities and challenges. You all know that sperm is a very unique cell, and the process of sperm production is highly complex. The testis is a factory. It produces millions of sperm every day, which is the sperm. Mature sperm is a terminally differentiated cell. It cannot progress unless and until it gets engaged with the oocyte. But the term artificial gametes are becoming quite popular these days. There are various reasons. What are these artificial gametes or artificial sperm? So nothing but the sperm cells which are generated by manipulation of progenitor cells. You can use stem cells. And these cells should have the ability to fertilize the oocyte, and they should have normal genetic and epigenetic makeup. So what are the applications? Why do we need to worry about this sperm? Because we know that the millions of sperm are produced every day, and why really we need to worry about this? The questions are the gonadal dysfunction and in same-sex couples, and more importantly in fertility preservation. If you look at this picture, it tells you the difference between the spermatogenesis and oogenesis. The spermatogenesis is a long process, it's about 76 days. And it's important to know that the maturation, the sperm maturation or the meiosis starts only after puberty, when there is a hormonal trigger. So it takes at least 36 hours for the final maturation. Interestingly, if you look at oocyte, the time requirement for final maturation is only 36 hours, from the time of GVBD to metaphase 2. So I always think, why men cannot be more like a woman? It's very easy, because spermatogenesis is a very complex process. Now let's look at what are the possibilities of deriving sperm. You can use stem cells, gonadal stem cells, and proliferate it, and then you can do autotransplantation. The autotransplantation is not very exciting in case of men, because it has been successfully shown in women, the ovarian tissue transplantation successful, but not in case of men. In vitro differentiation of embryonic stem cells, you can use embryonic stem cells and then do autotransplantation. You can use iPSC technology, induced pluripotent cells. You can use any somatic cells, reprogram it, and see that sperm is produced. You can also do in vitro somatic cell transformation into gametes, in vivo somatic cells. These are some of the possible ways where you can generate spermatozoa. So the immediate requirement of this technology is in fertility preservation. The fertility preservation, it doesn't belong to any specialty, but the fertility preservation needs a well-orchestrated coordination between various specialties. You need surgeon, you need psychologists, you need oncologists, pediatricians, fertility experts, and basic scientists. And this relatively new area coming up and is gaining importance, because if you look at the survival, the cancer survival rate is increasing. It's about 80% of children who receive cancer therapy, they become disease free because of the excellent treatment modalities. So that means more and more children are entering into reproductive period. Why we need to worry? Because it has been shown that the germ cells, especially the proliferating germ, these are the different subpopulations you see tested. These are the stem cell spermatogonia, the differentiating spermatocytes, and these populations are highly sensitive, especially the differentiating spermatogonia is highly sensitive to any kind of toxicant. Use chemotherapy or radiation therapy, it will completely destroy this population. But if you look at the differentiated, like the round spermatids, elongated, they are quite resistant, and it's not easy to damage this population. So what will happen? It's more clear here. If you look at the testicular population here, in childhood, what I want to tell you is that even the low dose is detrimental to the stem cell population, whereas in adult, low dose is only high dose. Whereas here, these are the somatic cell populations, the Sertoli cells. What I want to tell you is that even low dose can damage both the stem cells, sperm producing cells, as well as Sertoli cells. If supporting cells are destroyed, the risk of testicular failure is very high. It's clear, it has been clearly shown that the agents which are used in cancer therapy, especially platinum drugs and cyclophosphamide, they are dangerous. They can lead to irreversible damage to the testicular germ cell. Now you ask me, are there any proof saying that these agents are detrimental? In fact, 2 years back there was a nice review published in Human Reproduction. Here if you look at, this is the results of testicular sperm extraction, TSA results in oncological patients with the post-treatment azoospermia. They received oncological treatment during their childhood. When the TSA was done because of azoospermia, what I want to tell you here is in only 44% of people, they could retrieve sperm. That means about 50% of children who received chemotherapy, radiotherapy, they became azoospermic. The risk is more than 50%. So, what are the options for fertility preservation? In adults, we know it's very easy. Ask for the ejaculate before chemotherapy. The semen fry preservation is well established. But unfortunately, this option is not available for prepubertal boys because spermatogenesis is not fully functional. The only option which is available is the immature testicular tissue cryopreservation. And what to do with this immature testicular tissue cryopreservation, because there are no sperm cells. At present, we store them and develop a technique to derive sperm using those immature germ cells. There are several challenges in getting, though it looks very easy to ask for a testicular biopsy, there are several challenges, because if you look at here the testicular volume, what I want to tell you is that in adult testes, about 80% of the testicular volume is filled with the germ cells, the sperm producing cells, whereas in case of young boys, just about the 10% of cells in the whole testis contains the germ cells. So, chances of retrieving germ cells are much lower compared to adult testicular tissue. So, what are the options now? One is to propagate an autotransplantation of spermatogonia stem cells. You have testicular tissue with you. Separate stem cell population, amplify in vitro, and then go for autotransplantation. But the other option is gaining popularity is that in vitro spermatogenesis. Try to derive sperm in vitro, culture them, because autotransplantation also has a risk, because there is a risk of transplanting the malignant cell. The risk is higher, which doesn't happen in case of in vitro spermatogenesis. So what are the options? There are several approaches. Whether the testicular cells can be cultured like any cell culture. People have tried it, but the problem is that it doesn't maintain the spatial structure. You just mince everything. The structure of the testis is very unique. Okay, that cannot be mimicked here. So no sperm